Welcome everyone to the latest in our Open Learning Series events hosted by the Transformative Innovation and Policy Consortium, or TIPC. My name is David Brimage and I am the Global Programme Manager at TIPC. Really pleased to be joined by all of you today. For anyone who's coming to these sessions for the first time, this is a practitioner-led space where we consider different applications of transformative innovation policy tools and methodologies, and we look at each session at a different context. So this really provides us with an opportunity to share insights from that particular initiative or project, and we hope that those insights will then further inspire the work of policymakers, researchers, and other practitioners. One really key aspect of these sessions is it gives you all the chance to ask any questions that you've got or share your own reflections or experiences. You can do that throughout the session by adding your questions to the chat box. And then what we'll do is we'll make time at the end of the session to run through all of these. If you are able to, it would be great if you could leave your camera on, but we obviously recognize people have got lots of different things on and that's not always possible. Also, it would be a great start if people wanted to introduce themselves in the chat box, and feel free to share your name, which organization you're from, and your particular interest in today's topic. That would be great. So today's session focuses on a 5-year collaborative project between Colombia's National Cancer Institute and researchers within TIPC's Latin American and Caribbean Transformative Innovation Hub. And over these past 5 years, researchers have co-designed and implemented a co-creation laboratory. And that's really a transformative experiment inspired by the principles of transformative innovation policy. And the lab provides a space where patients, families, caregivers, health professionals collectively explore and design new approaches to comprehensive cancer control. It gives me great pleasure to be able to introduce our two main speakers to this session. Milena Osorio García and María Luisa Villalba are both researchers within TIPC's Latin American and Caribbean Transformative Innovation Hub. Welcome both of you. Thank you so much for agreeing to do this. In her research, Anna investigates participatory approaches to health system transformation with a particular focus on comprehensive cancer control. And María Luisa works on transformative innovation methodologies which are applied to health and patient-centered care, specifically within the Latin American context. And Anna and María Luisa, thank you so much for doing this. I know that you have recently shared this research in Spanish, and it was very well received. And I'm really grateful that you've both offered this opportunity in English to allow more people to hear about this important work. So I will stop there and hand over to both of you, and thank you.
Thank you, David. Well, good afternoon, everyone. We really appreciate your attendance and interest in this topic. Today, we want to share with you a case that has been particularly important for us, the journey that the Instituto Nacional de Cancerología has taken in recent years, trying to reinvent itself from the inside. And the question that guided this journey is, how can we rethink comprehensive cancer control from the experience of patients, families, and caregivers? What we want to share today goes beyond a methodology or a tool. It's an open reflection on the rigidities, the resistance, the learning, and unlearnings that emerge when an institution like this, deeply rooted in the system, tries to transform from the inside to give agency back to patients, caregivers, and their families. So my name is Milena Osorio, researcher at the Latin American and Caribbean Hub for Transformative Innovation. And I'm joined today by María Luisa Villalba, also a researcher at the Hub, who has been fundamental for this work. I also want to mention Dr. Álvaro Quintero from the Instituto Nacional de Cancerología, whose leadership has been essential to this process. And I hope he's with us in the audience today because his vision and his work are at the heart of what we are sharing today. So that question, how to rethink cancer control from the voices of patients, caregivers, and their families is what brought us today together. And over these years, the alliance between the Institute and the Latin American Hub has had clear purpose to support the Institute in an institutional learning process aimed at strengthening his capacity for transformative innovation in health. And that in practice means something very concrete, opening spaces where we could ask ourselves how knowledge is produced within the system, how decisions are made, and how different perspectives are integrated or not within the comprehensive cancer control model. This wasn't simply about applying a methodology, it's about generating conversations that normally don't happen within a highly structured institution. And today we want to share this experience from the different roles that we have accompanied this process. So the health system is probably one of the most complex and regulated systems there is. Unlike sectors like energy, food production, or mobility, here the regulatory rigidity has an undeniable reason, protecting people's life and safety. However, the same structure creates very marked characteristics. There is a strong hierarchy of knowledge where formal, biomedical, and technical knowledge is usually organized in a top-down way, while tacit experimental knowledge, the knowledge that comes from patients, families, and caregivers, tends to be made invisible. Additionally, the system has historically had a predominantly curative and hospital-based approach, which leaves little space for active agency of patients, families, and caregivers within the innovation processes. And to this, we add administrative rigidity, slow bureaucratic processes, strict regulations, and organizational structures that prioritize stability over adaptation. In fact, the recent debate about health reform in Colombia has shown how difficult it is to transform a system so structured with multiple actors, interests, and regulatory frameworks. So from the beginning, the Institute was not trying to transform the entire health system, but it did start to identify something very concrete within the structure. One component of the system, the management of health innovation, that had traditionally been focused on technical and institutional, with little or almost no real participation from patients, caregivers, and families in the design and decision-making processes. And that is where the Institute finds a possible space to intervention, not to pretend to change the entire system because it was almost impossible, but to ask itself strategic questions within the component. What does it mean to talk about transitions in health system, in a highly regulated system, and how we can move towards more inclusive forms of innovation without compromising patient safety? So working hand in hand and within the framework of transformative innovation, we begin to ask ourselves how to connect two forms of knowledge that normally do not dialogue within the system. On one hand, a formal technical and scientific knowledge that structures clinical practice that is fundamental to guarantee the quality and safety of care. And on the other hand, experiential knowledge that comes from living with the disease, from accompanying it day to day, from facing the uncertainties of treatment, and from navigating the health system day to day. So from this research framework, the purpose was to understand how to move towards a truly comprehensive cancer control that recognizes and gives agency and legitimacy to empirical knowledge of patients, their caregivers, and their families. That is to recognize that their experience living with the disease is not just a personal history, but also a form of knowledge that must be part of building solutions. So this entire process has developed progressively over several years. It begins between 2020 and 2022 with the creation of a co-creation laboratory designed as a space for dialogue between different actors in the health system to share their experiences and reflect together on the challenges of comprehensive cancer control, but also on how to strengthen their agency and participation in innovation processes within the system itself. From there, the process moved towards a phase of direct work with actors in oncology system. Between 2023 and 2024, we conducted 2 phases of research with patients, caregivers, families, and health professionals, where we applied a specific methodology called multi-criteria mapping. And finally, in 2025, we moved towards a new stage, focused on building theory of change, where we begin translating these learnings into possible paths for transformation within the system. And to understand these different positions, we use multi-criteria mapping, as I said before. Unlike a traditional interview, MCMs combines qualitative and quantitative approaches. During the interviews, participants not only share arguments and reflections, but also evaluate different options. So this allows us to generate both narrative information and numerical data, which are then represented in a comparative charts. And one of its most important characteristics is that the evaluation criteria are not defined by the researcher, but by the participants themselves. So this ensures that the analysis truly reflects their values, priorities, and ways of understanding the problem. But perhaps its greatest value is that the method allows us to capture uncertainty and ambiguity. On one hand, it captures uncertainty because participants don't have to give a single answer. They can evaluate options considering more optimistic or more pessimistic scenarios. And on the other hand, it makes ambiguity visible by showing that different actors can interpret the same problem in different ways. They can also assign weights to each criteria, showing which aspects they consider the most important in their evaluation. And the entire process is reflexive, iterative, which means people can review and adjust their responses during the conversation. So this allows to build a much richer and diverse vision of how different actors understand the system and how they consider key to improving comprehensive cancer control. With this methodology, we were looking for, within the Institute, was to explore new forms of participation that would allow us to give greater agency to patients, families, and caregivers in innovation processes related to the comprehensive cancer control. So the idea was that this actor would stop being only receivers of the system and could participate actively in reflection on problems and building possible solutions. And why was it so important to include all these perspectives? Because it's not, the cancer is not experienced in just one way. We can imagine, for example, that the health system as a prince, some problems, for example, the comprehensive cancer control model enter from one side, but it reflects into different realities depending on who is looking at it. What for a doctor might be a technical priority, for a patient or caregiver might have a very different emotional, social, or even economic meaning. And we understood that if we really wanted to move towards a truly comprehensive cancer control, we needed to make all those perspectives visible, the ones that coexist within the system. So what did we find with multi-criteria mapping? First, the analysis allows to identify 7 micro criteria, and above all, to confirm something that we had intuited, that there are important asymmetries with the system between actors in terms of communications, expectation, and agency. What we saw is that each actor prioritizes different things because they experience the system from different places. For example, caregivers and families tend to prioritize communication and information very highly because they often are the ones who receive the initial impact, they accompany the diagnosis, and sustain the daily process. Doctor gives more weight to education and technical knowledge because from their role, they need to make clinical decisions and guide treatment. Health professionals especially value timely access and support because in practice, they see how delays, barriers, and procedures affect the continuity of care. And patients also prioritize education and knowledge, but they attach these strongly together with the need to communicate, to understand what is happening, but also to feel accompanied in the process. Now, perhaps the most revealing finding was that these differences are not just priorities, but also differences in the meaning of the concepts. And the clearest example is communication. For many doctors, communication mainly serves as a clinical function, transmitting clear information, explaining diagnosis, and ensuring understanding and adherence to treatment. But for patients, communication is something different. It is a relational and empathic process because it is a place where fears are expressed, experiences are shared, and emotional support is received, not just for medical and technical information. And that leads us to a key conclusion. If we want real transformation to comprehensive cancer control model, we need to legitimize empirical knowledge. That is to move from a model that is exclusively biomedical, more top-down, to that combines formal science from lived experience, more bottom-up. At the first level, what we could call first learning, multi-criteria mapping allows to make visible the different priorities and perspectives that exist within the system. We could better understand how doctors, patients, caregivers, and family interpret the aspect of comprehensive cancer control model differently, such as communication, support, or access to the system. This allows to build a much more complete vision of the system challenges, integrating both clinical knowledge and the lived experience of those facing the disease. But perhaps the most interesting learning were the second order learnings. That is, the changes this process begin to generate within the institution itself. One of the most important challenges emerged when the Institute began to talk about experimentation. In the context of the Institute, like on other health institutions, the term experiment is traditionally associated with clinical experimentation, that is, with controlled trials related to treatments or medication. While innovation management within the institution is normally organized in terms of projects with defined budgets, set timelines, and expected result. That is why introducing the idea of experimentation in innovation and politics meant something changing that institutional framework. These were not clinical experiments, but institutional experiments that would allow testing new forms of participations, methodologies, and new ways of managing knowledge within the system. For this to be possible, the Institute had to create an institutional arrangement, and this approach was integrated into the institutional development plan, not as an isolated project, but as a part of a broad orientation toward transformative missions. And it was a place specifically within the knowledge management axis of the Institute integrated management model. This allowed the idea of experimenting in innovation processes to begin having a legitimate place with the organization, language, and practices. In other words, beyond the methodological results, this process opened a small but important opening within the institutional regime. And perhaps one of the most valuable learning is that transforming a system not only means learning new things, but also unlearning certain traditional ways of understanding how innovation happens within institutions. So we have condensed all these learnings into a policy brief, which we published last year. So I invite you to scan the QR code to learn more about this research. And to close my remarks and move on to discussing how to has transformed the Institute internally, I want to leave you with 3 major recommendations that came from this experiment and are the conclusion of this policy brief. Strengthen patients and caregivers associations. They can no longer be seen as a simple peripheral support groups. They must be empowered technically and administratively to be executors and political actors in the decision making. Co-constructed digital technology. The health system is investing in digital technology for patients, but it must be built with patients, not for them. Technology must be designed from the ground up, listening to vulnerable communities and responding to their actual needs, literacy, and cultural reality. And transdisciplinary communities of practice. It's important to form of practice where different actors from different areas and backgrounds could create new practices and policies together. These formal spaces allow them to develop new approaches, languages, and innovations addressing key issues like uncertainty, building transparency and trust in treatments and each other's capacities. So now I leave you with Maria Luisa, who is going to talk about how we try to translate these learnings into a practice. Thank you very much.
Well, very warm morning, afternoon, evening to everyone. It's an honor to greet you and be part of this space of reflection on transformative innovation. Following up on what President Bayana, the lesson learned and the strategic implement today, in our experience, generate a new question. A question that aims to take a step beyond the achievements we have made so far. How do we convert this learning into permanent institutional capabilities? To answer this question, we propose a new project with a new scope. Design 1 or 2 theory of change in the healthcare sector, following the recommendation previously get with the active participation of patients, families, caregiver, and of course the ANC teams. To tackle this new challenge, we structured a project around four key steps. The first step was preparing in an interdisciplinary team with strength in both innovation and public policy. The second step involved developing a participatory workshop to build the theory of change. The third step was to conduct a mentoring session to continue building this theory. And finally, the fourth step aimed to develop theory of change onto a formal project framework, and thereby finding a sweet spot between the flexibility that characterizes theory of change and the conventional structure of a project workflow. Why? Because the current way to work is by project. No theory of change is often used. The proposed plan was designed to span 5 months, and the detail is next. Okay, first and foremost, to understand this journey is crucial to recognize the unique characteristics and the complexity of public institutions, particularly those in the health sector, according to Anna said. To ensure proper operation and guarantee transparency, these entities are accompanied by high level of bureaucracy, reflect in rigid annual budgets and action plans that offer very little flexibility. Anna, please. Yeah. Secondly, like any institution, the innovation team has to confront the deep-sitting cultural tension of we always done in this way. And finally, we face the challenge of working with disconnected departments and areas that, in many cases, were collaborating for the very first time. So we decide to make an intervention, begin with the direct training for the core team. A core team was the group responsible for managing transformative innovation within the institution. Together, they co-design and run a workshop alongside patients, family members, and caregivers. Or at least the first experience of that. This workshop take place over 2 days. We start by providing a contest for the patients, and they move on to co-create a generic theory of change. For this exercise, we use a pentagonal map, which was falling out dynamically as discussion took place amongst with every stakeholder. Following this, after we set out the building to build a specific of theory. The group dynamic was good. Participants easy reached agreement and dove deeply into the most complex issues. For this task, we use a structure template. La anterior, Ana, please. La anterior. Yes, thank you. We use this template, the pentagonal map, for the generic theory, and this another tool where we can identify with the people, inputs, actions, activity, product, outcomes, and long-term impacts. Actually, the exercise is very flexible, but we don't can finish at this moment. So we take these inputs and continue the activity in the different mentoring only with the team, INC team. And second, this imaging show that we do only in the workshop, and the space was very good, and pain was shared, laughter broke out, and the conversation always try to co-create possible solution the same problems. Okay. After that, we conclude about the learning only about this exercise in the two levels. The first order learning in this step will translate into operational and functional improvement in the current capabilities. The first one is the team experience brand new way to relative healthcare staff with patients and their relative. Also, learning to handle resistance to change. The most important, they were able to identify the outdated institutional rules and processes that baronet patient care and urgently need to change. But we went ever faster, achieving second order learning. We are systematic and essential in nature. First, we understand the vital importance of setting modest, progressive, and realistic goals instead to making grandiose promises that are never kept. Second, we redefine the role of the ANC itself. The ANC is not merely a distant regulator. It can also take on an active role as facilitator, intermediary, and connector of the various actors within the healthcare ecosystem. And finally, we walk away with a home yet powerful truth. To truly transform, we must first unlearn. Well, let's dive deeper into this last point, unlearning. To transform any institution system, the hurdle is often not learning new concepts, but rather having the courage to let go of what no longer works. We must urgent question establish organizational routine and the regular strategies that limit the patient agency. Why should a patient be treated as passive subject who only obeys medical instruction? We must empower them as a key actor in the co-design of the institute's innovation processes. This forced us to change the traditional medical model that is focused on scientific area in order to move toward a much more systematic, preventive, compassionate, and human vision. The major challenge we face today is to ensure this value learning transcends the experimentation and contribute to the transformation path. Nana, next, please. Specific in unlearning, we focus because in the theory of transformative innovation, we use the term regime to describe the rule, but this rule is changing. This rule trying to protect the status quo, and in our case, is according the vertical medical scientific model, and treating a regime as robust, regulate, and rigid as healthcare is a titanic step. Nevertheless, with this project, the ANC has taken a historic step as key actor with a very regime is agreed to open up crash of flexibility. Anna, please. The next. Oh, no, sorry. I forgot the last one. Okay, no, I finished. Please, this was our work. I would like to open the floor to you. I invite your reflection, feedback, and question about this topic. Thank you very much.
Thank you so much, both of you. That was fantastic. And thanks for taking us through the research and the project. There's so much to process, I think, from this project. So that's given us a lot of food for thought. So we have got some time for questions, and this might cover a number of different areas. You might have questions about patient participation and power, or particular learnings from the multi-criteria mapping exercise, or questions about implementation and policy or wider implications. So please feel free. You can either put them in the chat box, any questions that you've got, or you can also raise your hand and ask the question directly, however you prefer to do it. Let's see. So I'm going to try and keep an eye on the chat box as well. While we're waiting for people to have a think and type in their questions, I had a couple of things that I was interested in, and I can see people here have questions and they're just trying to type them at the moment. I suppose I was wondering about the tensions that might have arisen. So I was wondering if in the work that you both did, were there any tensions between the professional expertise and the experiential knowledge from the patients or the families, so tensions that were difficult to deal with? And I was just wondering how those were handled as part of the research and the work.
Maria, do you want to go first?
No, because I need to the question writing.
Okay. Well, thank you, David. We did have some tensions, and that is normal. I think in all these processes, especially when you are trying to change an open system, and as I said before, it's a really rigid system and complex. So for the institute, inside they had this resistance, as I said, to put this kind of terms, when we are talking about experiment, and in the science, you think experiments in this work, and you're thinking in a lab with the trials and experiments. So this very beginning to try to put this new experiment and in management and innovation generated big tension inside. So they needed to find a way how to translate and how to find a way to apply this new technology, because the structure, the system, they didn't understand at the beginning. That is in an institutional way, but in practice also it was it wasn't a tension itself, but was interesting when we were seeing, or when we were talking with the patients and caregivers and families, when we asked them how they evaluate, the system, and they always it's a complaint, that they were always complaining. So if you don't know how to read this kind of comments, you stop just in a complaint. But when you go back to these words and what they are saying, is beyond that. So it's something that is not solved. So we need to look at it. And probably the differences between our health systems in global South comparing to the North, well, you have developed several things, you have a solution for many things, but in our context, these patients have social problems, mobility problems, economic problems. So this is all related to the system. So we need to look after these comments and try to know, what is behind, because if you just stop in the complaint, could be a problem. And that was we saw in a part of the workshops, when we invited one of the professionals, and she was in the whole process. So we were discussing something, and in that little moment, the patient started to complain, to say this, that, and she left. And after she said, well, this is something that is just complaining, but she didn't understand the whole process. She didn't have the picture, the whole picture. So that is interesting, because you need to go beyond that and have a bigger picture of the processes to see that. That is what I have to say. I don't know, Maria Luisa, want to complement.
Now, maybe another part that the passion that was in this experience is the same people that are working from 2022, 4, 3. and they want to participate in this process. They want. We don't have to convince someone to participate. But with the team in the ANC is a new team. They don't know nothing about transformative innovation. They don't know how to do that. And our role was to be in this in the path with them, but they couldn't start by themselves. They need to be with us. Maybe for the professional staff could be harder than the patient, because patient only go to the space and share, and this is a workshop, and yeah, but the other people have to understand their responsibility. It's not only the space, and that is the first experiment. So happened that Anna said, and people say, no, always is the same, and I prefer don't spend my time here. But maybe, and to connect with the next question, maybe the next step is work with the professional separate, and work with the team, because the team is not only for the transformative innovation at the institute. The 14 have another responsibility. So if they don't have time to do this, maybe this path take a long time.
Thank you. That's a really full answer, and there's a lot in there as well. Interesting, I think that discussion, Maria, Luisa, that you said as well about how you bring up feedback to medical professionals without it seeming like a complaint, and how you create an atmosphere where people feel able to share their experience in an open way.
It's impossible ask for someone that is feeling this skill business. It's impossible to ask, please be quiet, only is a word spec. No, they are human. They need to say that they feel. I think the way that people is working and is used to work, maybe they need to change before the patient change.
Absolutely. We've had a couple of questions that I think lead on from this quite well in terms of the workshop. So Maria Luisa, you spoke there about the different, maybe having workshops with different stakeholders separately, but we've also got a question about asking for a bit more information about how the innovation labs worked. What did they involve in practice? How much time was needed? And how did clinicians participate?
Okay, I can answer that because I was closer to that. The innovation laboratory, the co-creation laboratory was, as I said, a space. Think in a place where these two phases of the innovation can met. So it was difficult to show this other phase, that especially to researchers and doctors, because at the beginning the collaborator, the laboratory was more for those people in a scientific, medical design, treatments, innovation. But what the doctor Alvaro wanted is give this space also to the patients, caregivers, and families to experiment and innovate. So there is a space that the dialogue, and it has taken time because the institution needs to understand the function of these two phases of innovation, not only medical and this very scientific path, but also that there is another way, and also they want to that, for example, family patients can contribute to design some things. So maybe not in a medical treatment they cannot, but they can contribute to another parts of the innovation. That is what the institute wants, that in this space, in some point, the patients, caregivers, and families, they can have more agency in this part of innovation of the institution. So it's not easy, because also it's not easy that them, especially patient, family, and caregivers, that they have this role of innovators, that they have this agency, because all their lives they have been treated as a passive receptors. So when you change this way to say, okay, you can contribute, this is not easy to process and to match, and for the scientific and the doctors, they some of them they are not comfortable, because they're gonna say, well, this is a treatment, this is a really, what I say before. But there are some points in the different parts of the system that they can contribute. So in management, in the understanding the system, in some different ways, some technologies, and it is funny when you see, for example, some tools to get more, easy in the apps, the phone, and you can get access to this, but you don't see, because the technology, it wasn't designed with them, was by them, so they don't. Some of them, they don't understand that they don't know how to read, they don't know how to use and this is a lot that we talk about digital analphabetism, and understand. So there are people that only use WhatsApp and Facebook, no more. So there is a lot of things that are happening inside that actually they can contribute to the processes. So the lab is a space to they can match and they can work, but it takes time, because you need to transform several things inside of the institution. You need to get resources, you need to get those professionals that they are able to open and say, this is not just a formal knowledge, but we are able to listen, to talk, dialogue with informal knowledge. So that is an open space that for professionals and an institution as well. So, but this is interesting and the first in the country, and I'm thinking it has potential. And connecting to the other question, that if we were able to apply something, I think Maria Luisa can complement this, but we couldn't get farther from this tier of changes, because it was a small experiment. What we were trying was to help them to understand the capacity that they had to think differently, to do different things, and for them was a big learning to see that the patients, caregivers, and family, they can contribute and give very good ideas, and they could identify different problems that they saw the problem in a different way. So it was interesting to see the problem in different phases, but we couldn't implement something big. It was a proposal, and it was this theory of change was more like an exercise, internal exercise for the institute. But we are waiting, and we are expecting that they continue with this process, and we actually, what we were talking about in this exercise, actually start to implement in the institute. But that I said before, and Maria Luisa as well, even if it's not a big, implementation, for us it's a big learning because it's a really rigid regime, and that this kind of regime and this kind of institution that is one of the most important institutions in the country, that actually is rethinking and trying to unlearn things, is opening a small way to open this rigid regime. So for us it's a big learning and a big step that maybe we could improve in a future with the INC. I don't know, Maria Luisa, if she wants to complement that.
No, just the laboratory have the two way, the traditional way and the transformative way, and the traditional way work perfect. They can get money, they can get the license, and they can get the authorization from the manager, and it's easier. But this in transformative innovation, they need to prepare very much the project. They fight between what they want to do and they what have to do, because never is the same language. So they need to write. Sometimes they don't want, because we don't know what will be the result. So they say, why I have to do this this way? We know that they need to wait, and it giving a little step. Maybe in some years they can say, I have this lab with the whole team together, but now it's only the beginning.
Thank you. I think that's a really important point, Maria Luisa, and stands completely to sense. It makes sense that when doctors and practitioners are already very busy in their day-to-day jobs,
Yes.
of course, it's easier for them just to continue with the system that's in place and not try and innovate. And they don't have time probably to innovate either. That sort of leads us into Emilio's question. So Emilio was asking, and you've covered this a little bit, but did you feel that you were working with a number of different key actors, such as practitioners, patients, families? Maybe you could say something about how you felt the perspectives changed throughout the process, if they did change. I know you've touched a little bit on that already.
You can talk about that more. That was your part.
Yes. Actually, when we was finished the project, we have to finish the project because the plan is very rigid and we have to finish. But at that moment, when I talked to the team start to reflect only at the end of the process. So at that moment is the best moment to continue. So they by themselves, they say, oh, why in this project they are not someone and this area, maybe in this group have to be, I don't know the name in English, is the area have direct contact with the patients, and we do this without them. And they said we need this kind of person in this team. So maybe the next change, the next step, they can identify another career actor within the institute and outside, because we always wanted to work with the association, patient association, but we couldn't. So many things to do.
I want to quickly answer this question of Vicky. She asked about MCM, how accessible was to this method. Actually, it's really easy. I think is you need to at the first to explain a little bit more what is about and what they are going to do. And normally they are get used to this semi-structured interviews. So when you ask them to evaluate, to give weights what they are thinking, so it's a little bit confusing for them, because they don't know how to evaluate. So it's explaining the criteria that they have to evaluate the criteria and these options is the tough part of the methodology. So it needs to take time to explain this part of the methodology. But when this is clear, maybe what I did was to give them examples of what could be a criteria to evaluate. So, and when you give these examples, it's clearer, so they can give their own, and also when you give them give a value from a pessimistic or optimistic scenario, normally generally you get the pessimistic as the reality for us. So always was the pessimistic way is or what is happening now, and the optimistic scenario is the impossible to happen. So that is why that was something interesting for that. But for me it's easy. As soon as you explain this first part, they are not they used to this kind of methodologies and dynamics. And at the end, you asked also about the pentagonal, I think, the
Oh, yes, there's a question about the pentagonal map.
The challenges faced the system, I think, is one of the challenges is when you start to think about the dimensions, and especially with the rules, especially informal rules, because you are not used to think about that. So, but it's really interesting when you get there and explain what does it mean, and they start to think about all the things that the system has, and a lot of ideas come up. So the exercise is interesting. It's not difficult. At the beginning, is as I said before with the MCM, is explained very well each dimension and each level. So what does it mean? And give examples. As soon as you get this, they get the idea and start to identify the elements. And we did it for the system and for the niche. So it was really interesting to see the alternative that that we have and the system, what I was doing.
Thank you, Anna. I'm aware that we're starting to run out of time, but there's just one last question that I think it would be worth just briefly answering. So Leia had a question: did you co-create an intervention as an outcome of this work and the project? How did you implement it? And was there, did you face resistance, and what barriers did you face?
I tried to respond that before, and Maria Luisa as well, is that we couldn't get the intervention as an outcome. It was more like a theory of change. We did the exercise, and they reflect, and the team inside of the institute, they learn a lot of things, and they learn that they could, and they must work with different offices, not only with them. That it was more interesting to work with the patients and caregivers to propose this kind of interventions. But the barrier was the time, the budget, and more than that. So we couldn't go further from that. We wanted, but it was out of our capacities and the IMC in that moment.
Thank you. No, thank you. That's really useful. Maria Luisa, was there anything else you wanted to add to that?
No, I thinking that barrier will be for many years still there. We know that is very difficult. The system is very rich. It's so rich. And when we were talking, we can do that, they said, no, we need to full this. And then we are happy because we take a little point in the system, and maybe they find the way to continue that.
Absolutely. I think we can all appreciate how rigid a system like healthcare and cancer care would be, and how many regulations you would have to comply with. So thank you so much, both of you, for this session. It's been really fantastic. Thank you for taking us through the project, and again, thank you so much for offering it in English. It's been really great to be able to offer it to an even wider audience. And just to let you know, this session has obviously been recorded, and so we'll upload it to our YouTube channel, and that will allow people in different time zones to watch it as well. And I suppose I wanted to say, given just how many people's lives are touched by cancer, this is really important work, and it's definitely going to be one for us all to keep an eye on as it continues to be developed and hopefully gets additional funding to continue. For everyone who's come along today, oh, sorry, Maria, Luisa, did you want to say something? No? Okay.
No.
So we'll keep our fingers crossed for more funding.
Exactly.
And,
for the research.
Exactly. And thank you so much for everyone who's come along today. If you're interested, please take a look at the TIPC website and our LinkedIn account. We'll publish more details from this and any other TIP-related projects from the hubs and partner organizations that are running. That just leaves me to thank everyone for coming. And Anna and Maria, Luisa, thank you so much for today.
Thank you very much.
Thank you so much.
Thank you. It was a pleasure.
Bye.
Have a nice
Hi,
day.
Claudia.